Now, our next talk is on rehabilitation of groin injuries, and it's by Andreas Serner. Now, Andreas is sprinting for the finish line of his own PhD on the topic of acute groin pain injuries in multisport. So I look forward to your talk, Andreas.
Thank you very much for the introduction, and thank you for having me here. It's a pleasure to talk about one of my main interests in sports medicine, and probably one of the reasons why I'm working with this today. I was a football player myself and suffered from a few groin injuries, so I've been working with that since. No disclosures. So if we look at the evidence in the treatment of groin injuries, we can see that there are a few published reviews. In 2009, we had a study, systematic review looking at exercise only including 5 studies, but going a little bit more into detail with the different elements of the exercise treatment programs. And later on, 3 more reviews in 2013. We had a big overview of, thank you, or a big Cochrane review, which only included 2 studies due to the stringent inclusion criteria. And then here last year, we had 2 larger reviews where you can find a big literature list. So if you're interested, I'd recommend you to go into these details. Both have a nice data extraction supplementary appendix where you can find the different studies included. So a lot more of those, one of them from our group here at Aspetar with myself included. So if we're looking at that study, we had 72 studies included, so all within different treatments of groin pain. And we can see that the majority of the literature out there is on surgical treatments, and only 1 in 4 is on conservative treatments. And even less of these actually involve exercise as a therapeutical management form. So that limits what we can say. But if we look at the overall results, regardless of treatment, regardless of diagnosis, we can see that there's a fairly high success rate, but the return to time is very varying, so around 3 months, but with a large variation in the measures and the means. So one of the major things that we found in our study was that the description of these treatments was very, very poor, and the quality of reporting of the studies were also very poor. And this is something which is really, really important to consider when you're reading literature on groin injury management, and something that would likely affect the results included in the studies as well. So one of the things that we found was that you have lower study quality based on an objective score that we had 2 separate scores performing. We could see that the lower quality score, the higher success was reported in these studies. And that really makes sense to look deeper into when you're assessing your literature. So if you want to go in, we want to base our clinical approach on this evidence. We want to know that we're doing the right thing and that our studies are not biased. So we can set our cutoff values differently, and as we did in our study, we set the point of a 19 score, and this Downs and Black score that we used. We can see that actually out of these 72 studies, only 4 of these studies were included to be able to guide us with more moderate evidence, and I'll get back to that. Another major thing in these studies was the differential diagnosis, so the different terminology used in these studies to diagnose this pain in these patients. So we can see in 72 studies we had 33 different diagnoses, so that's really complicating things when we're looking at it from a management point of view as well. And fortunately, we're hoping to get closer with that. We have the Doha Agreement paper in the BJSM a couple of years, which was published last year, where we're trying to do some more overall grouping of these patients, which can also guide our treatment. But still, there are a lot of lot of these players which have multiple entities, and if we're looking back at the literature, it's still difficult to categorize these studies and the reporting in these studies within the different clinical entities. So in this review, we had 72 studies, as I mentioned. The majority were on long-standing groin pain, and we know about 2/3 out of groin injuries are related to the adductor, so can usually be categorized as adductor-related groin pain. And if we look at the other review from last year as well, we can see that the studies including rehabilitations is very, very low. And if we look at the pubic and abdominal-related groin pain, we can see that only 7 studies have included rehab on them, and only 12 subjects included. So how can we actually base our information or our clinical practice on this evidence? It would be really hard. So I'm going to focus a little bit more on the adductor-related injuries, which we can see has a lot higher subjects, but still not impressive. And also looking through these descriptions of what is physical therapy, and in these studies, we can see that a lot of them really do not describe the actual approach, so we're not able to replicate that in our clinics. One of the most famous programs is the Holmick protocol, which came out in 1999, where there's a clear description of the exercises that we can do, and timeline and number of sets and repetitions, so we can actually reproduce this in our clinic, and it's been used several times in other studies as well. So from 72 studies, we can see that in the adductor-related groin pain, only 2 studies reach sufficient quality to be able to guide us with some form of evidence. And what we came out with is there's moderate evidence that this exercise program that I showed you can provide much higher success and number of athletes returning to play than a passive physical therapy could. And similarly, the multimodal treatment program also comparing to this exercise program also provided good results in success and return to play. So with these studies, using this exercise as a treatment, what can we actually expect? So if we're looking at these 3 studies, we can see that if we use this exercise program as a supervised program, about 2 out of 10 athletes do not return to play, but the majority will. So the exercises work. But it's also quite a long timeline. We can see more than 4 months as a mean time. And that's similar for the same program used in the other study. But here, regardless of whether they use the home exercise program or the multimodal treatment, only about half of the patients actually return to play. So not the best outcomes. So this is kind of where the evidence leaves us in rehab of groin injuries. We don't have that much backup in our choices and the evidence to kind of guide our approach in terms of what we'll actually do in the clinic. So one of the things that we do here in Aspetar, and one of the things we're working on now, is developing more criteria-based programs and focusing more on the specific elements of the exercises that we have. And this is just one way of blocking your focus, so your groin injury treatment. And this is very important. When we're dealing with these complex presentations, it's important to prioritize your time and do that consciously so we can get the best results. So if we're looking at the different steps, and this is just one way that I use to prioritize my work, is that if the player is in a lot of pain, of course, you got to take care of the pain. You might use some analgesics, or you use your manual treatment. But what you want to do that for is to get to the loading. We now know as physiotherapists, we've known that for a long time that exercise works, but we now also have more evidence that loading actually leads to cellular repair. So a cellular response that we want to get started as soon as possible. So a lot of the times we get patients in and they've been resting for 4 to 6 weeks, and haven't been doing anything. So we really need to get those guys moving and focusing on this injured structure. Then we also want to be working on the indirect load on the injured tissue. If we're going back to the adductor-related groin pain, we can see that there are probably many other structures involved which can influence the load on the adductor insertion, which is most commonly the painful one. So focus on lumbopelvic strength and stability is definitely important. But another very important thing is that you really need to spend time explaining to these patients that the uncertainty in the diagnosis is okay. We don't have any good evidence to actually tell you how long it's going to take from these. As we heard from Dr. Mushavec earlier, a red card would be much simpler. And this is something which can highly affect your treatment. So spending time to explain what our working diagnosis and how we set goals rather than have a prognosis of the actual time to return to play is important. And then we want to be working on other sports-specific injury risk factors, for instance, and increase the fitness. We'll hear about the hamstring rehab protocol here in a minute. But that's very relevant for football players, so get some of those exercises in your treatment program as well. Again, with the adductor-related groin pain, we have different tools, or we have different ways of choosing what we'll do. We did a study on muscle activity in different exercises focusing on the adductors. And we can see just based on the different choices of exercises, we can adjust the load, and even within these exercises, we can adjust the load as well. So that's very, very relevant, the knowledge about how much the different exercises actually load the injured area. And then as a further step that we need to get not only in our daily clinical practice but also in research is all the different elements that we can control during our rehab, such as the intensity, how much do we want to load them, how many sets and reps, do we just want to do 3 sets of 10 on everything, or do we want to get more specific, do we want to start with a low load with a high rep, or do we want to start higher already as we can from the beginning? Do we want to go to failure? Do we want to do full range? Do we want to do inner range isometrics? All of these things are very important, and specifically the level of pain. So what are you accepting in your daily practice, in your treatment? Are we only doing pain-free activities, which might lead us ending up to having the player on the bike all the time? Or do we want to accept some form of pain during the rehab? Do we want to say 2 out of 10 is appropriate, which we do with the acute groin injuries at the moment? Do we want to try to increase it to 3 out of 10, which you do in some tendinopathies? All of these elements that you really have to think of in your rehab progress, which sometimes is omitted and not structured and varies a lot from patient to patient. So just to make this quick is that the overall evidence in the groin injury management, and specifically for exercise rehabilitation, is that the evidence is poor. Not all athletes return to play, and that's a very important point. Is that that's a very important point. Is that we really need to tell the patients that using this exercise is not a guarantee for success, and there can be longer timelines. But exercise do seem to work. So if we just want to do rest and passive physical therapy, we're not going to get the results that we want. Thinking about the cellular repair that we get from the loading is really, really important. And then the prioritizing of your treatment, do that consciously. Focus on the direct load on the injured structures and also the indirect load, and have that as your basis before you start looking at the other elements which might affect your general treatment. And then consider the adjustable variables in the exercise program, all the different elements that you can actually work on and include different elements and try to do that continuously, so you get a feeling of what is it that works and where can you adjust to be able to target the specific patients. And definitely include more running and change of direction programs for specific exercises. So thank you.